Hello everyone, today I will present our work on using a virtual peer mentor to enhance social presence and reduce stress in immersive virtual reality-based cardiac rehabilitation, specifically for patients recovering from acute myocardial infarction or AMI. Immersive virtual reality has been increasingly adopted in rehabilitation contexts. By combining gamification, serious games, and immersive feedback, IVR systems can transform repetitive rehabilitation exercises into engaging experiences that support motivation, adherence, and motor performance. In cardiac rehabilitation, this potential is especially promising. Early phase rehabilitation after a heart attack often involves low-intensity, repetitive exercises performed in bed, which can be physically safe but psychologically challenging. Despite these benefits, many IVR rehabilitation experiences are still perceived as empty and socially isolating, particularly by middle-aged and older patients. This is a critical issue in cardiac rehabilitation because psychosocial factors like loneliness, stress, and low perceived social support are strongly associated with lower rehabilitation adherence, poorer recovery outcomes, and higher readmission rates. In hospital settings, AMI patients often perform rehabilitation alone, while coping with fear, uncertainty, and emotional distress. When this isolation is reproduced in VR, the immersive environment may unintentionally increase pressure and tension, rather than reduce it. Previous research in IVR rehabilitation has extensively explored feedback mechanisms, including visual feedback such as progress bars and animations, auditory feedback such as rhythmic cues, haptic feedback such as vibration. Many systems also integrate virtual avatars, usually designed as virtual instructors, coaches, or task demonstrators. These approaches successfully improve movement accuracy and task completion, and most studies report increased engagement. However, we have identified three critical gaps in the existing literature. Firstly, most feedback mechanisms focus on external performance correction, but largely neglect internal psychological processes such as stress regulation, emotional reassurance, and perceived companionship. Secondly, avatars are typically designed as authority figures or instructors, not as peers. They rarely aim to create social presence or emotional connection, which are essential in rehabilitation after a life-threatening event like a heart attack. Thirdly, many studies rely on healthy participants rather than actual hospitalized patients. This limits ecological vitality, especially for middle-aged and older adults with physical constraints, fatigue, and anxiety. So to address these gaps, we propose a virtual peer mentor, or VPM. Instead of acting as a coach or clinician, the VPN is designed as a peer who has already recovered from a similar heart attack. Our design is grounded in social support theory, which identifies three key forms of support that buffer stress. Firstly, informational support helps patients to understand what will happen and what to expect. And secondly, instrumental support helps provides patients with practical guidance for task execution. And thirdly, emotional support offers patients encouragement, and companionship. We integrate all these three forms into gamified IVR cardiac rehabilitation game, specifically designed for bed-based early phase AMI rehabilitation. Based on this approach, we asked two research questions in this study. The first one is, does integrating a virtual peer mentor reduce short-term pressure and tension while increasing behavioral involvement in IVR-assisted rehabilitation for middle-aged and older MI patients? And the second one is, what key factors influenced the acceptance and experience of IVR-assisted rehabilitation in this population? Our system consists of two main components. The first one is a gamified IVR rehabilitation platform, and the second one is a virtual peer mentor. The rehabilitation game includes 5 clinically validated exercise stages, including arm raises, shoulder rotations, ankle pumps, leg raises, and glide bridges. All exercises are performed while lying in bed, following early phase cardiac rehabilitation guidelines. The VPM appears in 3 modes: narrative mode before exercise to share a recovery story and expectations, guidance mode during exercise to demonstrate correct movements as a translucent peer, and companion mode, remaining beside the patient, offers verbal encouragement and supportive gestures. We conducted a within-subject study with 30 hospitalized AMI patients aged from 47 to 78. Each participant completed 1 session with the VPM and 1 baseline session without the VPM on separate days. We collected intrinsic motivation, inventory scores, and social presence measures, cybersickness data, in-game performance metrics, heart rate, and semi-structured interviews. The most important quantitative finding concerns pressure and tension. Participants reported significantly lower pressure and tension in the VPM condition compared to baseline. We also found a significant increase in behavioral involvement that indicates that participants were more actively engaged when the peer mentor was present. And there were no differences in task performance, no increase in heart rate, and no increase in cybersickness. And regarding the interview data, over half of the participants explicitly described the VPM as comforting, encouraging, and reducing feelings of loneliness. And the acceptance for the overall IVR experience was high. 76.7% of the participants expressed the willingness to use the system in future rehabilitation. There were also some participants requested more content variety, higher challenge levels, and improved motion tracking stability. And a small minority of the participants preferred real human interaction over any virtual evidence. This study has several limitations like a relatively small sample size, short-term evaluation, and a hospital-based setting only. So the future work will explore long-term studies, adaptive or AI-driven VPMs, alternative mentor representations, and improved motion tracking robustness. To conclude, this work makes 3 key contributions. Firstly, it introduces a virtual peer mentor based on social support theory. Secondly, it demonstrates that peer-oriented social feedback can reduce stress and increase engagement in IVR rehabilitation. Thirdly, it provides empirical evidence from real hospitalized AMI patients rather than healthy participants. Thank you for your attention.